let me clarify first, because Elaine Wynn's program is the daughter company of Nathan Edelson Hospice, but it's important for me to clarify first that palliative care is not hospice care. Palliative care is a new and emerging field in medicine, and we're going to go over exactly what it is, exactly why the need arose, and what the future sort of holds, and then I'll have time for you to ask questions at the end. But I've given this discussion before, and I think it's important to clarify right up front that it's not hospice. This is an emerging field of medicine. So thank you so much for letting me come out and talk to you today. All right, so palliative care defined. Palliative care sees the patient beyond the disease. It is a fundamental shift for the focus of healthcare delivery. Palliative care, also known as palliative medicine, is specialized medical care for people living with advanced illnesses. It focuses on providing relief and symptoms caused by advanced illness. Whatever the diagnosis, whatever the prognosis, patients are typically receiving curative treatment while on palliative care. So palliative care is provided by a team. So we have a palliative care medical director who's board certified in palliative services. We have RNs, social workers. We also have complementary therapies for patients that need it. So massage, aromatherapy, that sort of thing. And we do have spiritual support if the patient asks for it. What led to the need for palliative care is that when hospice was sort of founded in the 1970s. Over the last 30 years, it's become its own independent and strong medical field. What people realized during hospice care was that hospice patients with the same diagnosis, given hospice treatment or no treatment, actually had a longer life expectancy. So they started to look into why that was occurring, because it was a surprise result. It's because the hospice team, the nurse, the physician, everybody is so focused on the quality of life of the patient and the caregiving system as a whole. And so they had the great idea over the last 5 or 10 years that that concept should be applied to people with advanced illnesses as well, not just patients with a terminal diagnosis, but patients who are struggling with advanced illnesses that are trying to get better, that their outcomes would be better if you applied care for the family, education for the family, home support, 24/7 kind of call numbers if the patient and family have questions. And the initial results, which they've been measuring really precisely for the last 5 years, are really, really impressive. Patients have fewer hospitalizations, they have better quality of life, they understand that they have better control over their own medical decisions. So palliative care has been positioned as a partial answer to a known gap in our healthcare system where patients return to the hospital over and over again. We have this horrible gap where we have people who are really, really sick and on hospice and people who are pretty well. And then we have all these people in between where when they really get sick, the only option they have is to go to the ER, because when you try to call the physician, what do they say? Well, I can take you in 2 weeks. It's not like you can get in there the day you wake up with a fever of 104. So we try to get palliative care involved to help those people who are in the middle, especially when they start to get advanced illness, and the ER is a must-have as soon as they get sick because you don't know which way it's going to go for them that day. People are living longer with chronic conditions. They also have more access to healthcare information. So with that comes a lot of decision making that the physicians don't always have time to sit down and go through with the patient and family. I mean, you can have advanced cardiac disease and 20 million decisions on the table, but the physician is usually in and out. They have maybe 10, maybe 30 minutes for a patient, but a longer discussion than that is rare. So the palliative care team comes in and helps the patient get resources, find community resources, and to help them sit one-on-one and understand the complexities of their disease. There are over, just in Clark County, 240,000 seniors in 2010, and that number is ever increasing. It is estimated that by the time we get to 2020, 17% of the population will be over 65 years of age. And those are the people who are most affected by that big gap in healthcare. Serious illnesses are highly likely to need pain and symptom control. coordination among the providers, and assistance in transitioning between care settings. One of the things we see often is that the patient will be discharged from the hospital, they get home, and they've been given instructions, but they aren't exactly sure how to implement that, or the doctor's office isn't answering. The palliative care team will come in and help the patient sort through all of that, get a hold of the doctor's office, get home health in if they kind of have a decline as soon as they get home. Most of our hospital readmissions we see within the first couple of weeks of discharge. And so palliative care is a way to help patients not have to bounce back into the hospital because they have an advocate who can reach out to their physician, their oncologist, their cardiologist, and get them the help they need without having to go through the ER. More than 80% of patients with chronic disease say that they would avoid hospitalization if necessary. And I think anyone who's been in the hospital even for a couple of days would say that's a good place to avoid if at all possible. Who pays for palliative care? So we have 4 places that we provide care. We do inpatient hospital consults where a palliative certified physician or nurse practitioner will go visit the patient in the hospital to address pain, nausea, anxiety, some symptom that's over a 5 on a 10, and coordinate with a hospitalist inpatient. Those visits we bill for. We can also send that provider to the home if the patient is homebound and having symptoms that are not controllable. We also have services at home. So we have a team, an RN, a social worker who see patients in the home. I have about 97 patients on service now. 30 are in Pahrump, the rest are in Las Vegas. That program is entirely funded by the generosity of Elaine Wynn's grant. There is not an insurance that reimburses for palliative care right now. So Elaine Wynn's grant is the thing that supports us with our community patients. Many items and services are coordinated by the home care team that are covered through insurance: home health, medical equipment, medications, medical supplies, private caregivers, that sort of thing. The goals of the Elaine Wynn Palliative Care Program are to improve the quality of life for the patients and their families as they go through their advanced illness. We want to reduce hospitalizations by being in contact with the patient and family and training them to realize which triggers really do need a 911 call and which triggers we could probably help them with at home by putting a call into their physician. We want to provide an interdisciplinary approach to patient care so the patient feels like they have resources from nursing and from social services. We like to address the entire patient, so not just the disease. Patients aren't just COPD, they aren't just cardiac. They're a physical person with an emotional and a spiritual aspect to their lives. We target 4 main diagnoses because honestly, palliative care, you could target everybody in the valley. At any point, someone feels really, really sick and could use some extra help, but we don't have limitless funds, so we did have to narrow down our target diagnosis. So we focus on patients with cancer, COPD, cardiac disease, and advanced renal disease. We will take other patients on a case-by-case basis. We have several patients from the Cleveland Clinic with MS. We take those patients on service when they're in a crisis. We help them resolve their crisis, and then once we have them independent, they have education, then we release them back into independent functioning, and they call us if they need us again in the future. I touched on just a few minutes ago, but we do have 4 levels of delivery. So inpatient consults, we have the home program, which provides for an RN navigator the first 4 weeks, a nurse practitioner to the home if the patient needs, complementary therapies, volunteers. We also have the outpatient clinic at Turo, so patients on the home care program who say they've been on the program a couple of months and everything's going fine, but then they suddenly have pain 8 of 10 that's persistent, we can't get it managed. They can go to the Turo clinic to see one of our palliative consultants there. And that, just so that you understand how that works, when they see a consultant, the consultant then communicates with the primary care physician. So the idea is to have the community of physicians all working together, not just one doctor here giving instructions and another over here giving instructions. The team works to have all of the physicians in coordination around what the patient has identified as their goal and their identification of quality of life. We also provide inpatient care occasionally. I've only done it twice over the past year, and that's for patients who, for example, I have an MS patient who was in and out of the hospital every few weeks because she would just have pain 10 of 10. It was from her MS. So she was taken into our inpatient unit for a couple of days because the pain was directly related to the MS, and we knew that we could resolve it in the IPU without making her go to the hospital. In a case where the patient has a symptom that we don't think is related to the primary illness, though, we will recommend that they go to the hospital because all of our patients are in full curative mode, and we want to make absolutely sure that if it's something serious, something that could be life-threatening, they get the treatment that they need. When a patient comes home from the hospital or calls us from the community to start palliative care, we send an RN out to the home in the first 48 hours. That RN will admit the patient if they agree with what they want from the program, and they'll visit once a week for the first 4 weeks. The social worker will also visit within the first week. We started the social worker visits because I found when I started with the program that half what the nurse was doing really was social service. There were financial needs with people who have new advanced illness. There were caregiver breakdown issues. There were all kinds of things that a nurse really isn't the perfect person to identify and resolve. So we send a social worker out to help get the patient and the family through those psychosocial needs. After 4 weeks, we have an interdisciplinary team meeting. And at that meeting, all of the people involved in the care meet and discuss how much support the patient needs for the following month. Usually the patient gets backed up to monthly visits with phone calls from the nurse on the weeks when they don't get a visit. If a patient on our home care program goes into the hospital, we do have the hospital team. So physicians and nurse practitioners who are palliative certified will go visit the patient in the hospital and do a palliative assessment and make recommendations to the attending hospitalist. We'll also send a liaison to the hospital to make sure they coordinate the care with the hospital case manager and family so we can get an updated record of the patient, and then when the patient goes home, they'll go back to their weekly visit schedule for the first month, just until we're sure they're stabilized. We take referrals multiple ways, one through the 24/7 palliative line, also by emails, and then we have a fax machine as well. To get a referral to the palliative care program, the patient does need to ask their physician because we do, like I mentioned, rely on the primary care physician to continue overseeing the patient's care. When the nurse goes to the home and sees a need, she will not call our physicians for the order. She'll call the patient's primary care physician for the order. Any questions? No questions?
Question from Elko.
Yes?
Is this care just down in Clark County?
This care, we provide services in Las Vegas and Pahrump.
Okay, thank you.
You're welcome.
Do you understand? How many patients do you have here in the facility?
So
No, this is Hawthorne and we are here.
I'm sorry.
So let's take that.
I'm sorry. Can you hold your question for just 1 minute? We just had a question from the audience about how many patients we have here in Las Vegas. So we have 98 patients on home services in Las Vegas. They all live in their residence, and we go visit them at their home. And then we see approximately...
I talked to a son that's in overseas, and he's been in the military, and he used to tell Dad to quit jumping out of the back.
So could you ask
Sure,
the remote
you see
sites
this
to
is
mute their
your
microphones until they have their question?
And so,
They have their mics on.
I'm sorry, remote sites, would you do me a favor and mute your microphones until you have a question, please? Thank you. Okay, so I'm going to repeat her question. She asked me how many patients we had on service in Las Vegas. We actually cover Las Vegas and Pahrump. So we have 98 patients in Las Vegas and Pahrump. 37 are in Pahrump, the rest are in Las Vegas. And then we do about 6,000 inpatient hospital consults a month. Any other questions?
Is that Las Vegas and Henderson?
Yes, right. I'm sorry, I should have clarified that. Right, it's Clark County.
You had another remote question. Can you ask?
Did they have a question?
Yes, from some remote site.
Did you have a question from the remote side? No? I don't think so.
Okay. I thought another site did.
Had any of you in the audience heard of palliative care before? You hadn't?
Can't hear anything.
You can't hear anything?
Nothing. She can't hear either.
Oh, I'm so sorry. Is that the general consensus that nobody heard?
Yeah, we can hear you.
You heard?
Yeah.
Okay. Were you able to hear me in the back? Yes? Okay. So had you heard of palliative care before? No. So this is something even Medicare, just so that you know, Medicare is undertaking research and providing grants to companies. There are 5-year grants to see if this is something that Medicare may consider covering in the future, because it does fill in that gap for patients who, they don't want to live in a nursing home, they don't want to go to the hospital every 4 months, they just really want to have good quality of life. So Medicare probably in the next 10 years will be reimbursing for palliative care. And we found with our patients, they do have much better quality of life and reduced hospitalizations, just because they have a 24/7 number where they can call a nurse and ask advice if they wake up at 3 a.m. and they're not quite sure if they need to go to the ER. Sometimes it's just as simple going through the medications and telling them what they should take and getting a nurse out to visit them the next day.
2 questions, Carolyn. One, you mentioned that you're only in southern Nevada. What would you recommend for our remote sites if they're looking for palliative care?
So palliative care is something, I'm trying to speak up, I just don't have a big voice, I apologize. So palliative care is a program that's developing all over the nation. This is not just something that we've concocted, it's something that's nationwide. And so for remote sites, I would start with, like in Reno, I'm sure they have hospices that are attempting to provide palliative care programs, because it is something that everyone in advanced illness care is very interested in, and they may have programs for the rural sites. For example, we provide a lot of telephonic support. We have some patients who live just outside of Pahrump, and they really are too far to get to weekly, but we'll call them to check on them and provide, consultations, and we'll go out and see them, once every 6 months or so, or if they really need a visit. But it saves them. A lot of people who are in rural communities, it's a big trip for them to pack up and go in and see their doctor, and so they tend to want to just stay home, and this is a nice way for them to have access to a clinical resource from their home. Any other questions?
Well, can you tell us a little more about Nathan Allison Hospice and the work that's done there in addition to palliative care?
Absolutely. So palliative is care for people who have advanced illness. It's a way of looking at the patient as a whole person, physical, spiritual, emotional. Hospice is a type of palliative care that is reserved for people who have a reasonable prognosis of 6 months or less. They have a disease that is not going to get better, and the patient is no longer a candidate for curative intervention. So Nathan Allison Hospice, which was established in the 1970s by Nathan Allison, who was the Sunrise Hospital administrator, and he unfortunately passed away of cancer, and it was a really, really miserable experience. And so his family was very close with the Moyers, who run the newspaper. They banded together and said, this should not happen to people. This should never happen to anyone again. And so they put their money together and created Nathan Allison Hospice. They built the second inpatient hospice unit in the nation, which is the one on Swenson Street, which we just did $1 million remodel on last year. So we're excited about that. But the hospice provides for patients who are not going to get better, and most of them are on home care. So we have about 350 patients most of those patients are at home, and so we send nurses and social workers, equipment. Medicare, they do a beautiful thing with hospice. They cover absolutely everything that's related to the terminal diagnosis, all the medications, all the staff, all the equipment. It's all provided for under the Medicare A benefit. If the patients go into crisis at home, they come into the inpatient unit so that their pain and symptoms can be resolved right under the watchful eye of a physician, a nurse, a social worker. And then when the symptoms are resolved, the patients return to their home environment. Have any of you had experience with hospice?
How many hospice units are there in Las Vegas and Henderson area now?
The question is, how many hospice units are there in Las Vegas and Henderson now? And do you mean how many inpatient units do we have, or how many hospice companies are there?
How many hospice companies?
There are, last I heard, and the count changes every day because some hospices, you know, put up a sign and have 3 patients. But last I heard, the hospice count was somewhere in the 60s. There are a lot of hospice companies, but it's important that you evaluate the quality of the hospice when you're making a decision. And one of the things I'm really excited about is for hospitals, they have Medicare reporting that you can go to Medicare.gov and look up your hospital or your nursing home and see what their scores were, see if they had any complaints. It's very transparent information. And starting next year, so they're starting the surveys this year, but as of next year, all hospices will also be on that Medicare.gov website. So you'll be able to pull up any hospice you're considering and review their survey scores, their satisfaction results, any complaints or compliments that have been filed about them. They'll all be perfectly visible on the Medicare website. So that will be really helpful for those of you who might have to look at various healthcare options. Yes?
Do hospitals have a hospice unit oftentimes?
The question is, do hospitals have a hospice unit? So typically no, because hospitals want to reserve their beds. But for example, we with the hospitals have what they call a general inpatient contract. And those are utilized for patients who are so fragile that they couldn't be moved from the hospital to another location. So for example, we'll use them if a patient, the family's decided that they're going to remove the ventilator support. We'll put them on general inpatient status in the hospital, and they'll take them off the vent, and the patient usually passes there. But the hospital contracts, when they exist, are not set up for several days. They're set up for emergent situations where it's just not humane to move the patient. It's a little bit different in rural communities. I'm from a rural community in northern Nevada, and I know there, when my grandparents passed away, they were on hospice, but in the hospital. So they must have general inpatient contracts and utilize them more because they don't have inpatient units in Reno, Gardnerville, Lake Tahoe, those sorts of areas. Any other questions?
The front one says that this is appropriate for any age, so
Exactly.
how young?
We
Right,
see,
patients.
so Dr. Cabanilla, our medical director. Oh, there's a question? Okay. Repeat the question, I'm sorry. The question is there an age limit on the patients that we take? And so Dr. Cabanilla, our medical director, has even consulted with mothers who are pregnant and know their baby won't survive. So there is not an age limit for palliative care. We don't have a lot of peds because usually, I mean, even for me, you do absolutely everything you possibly can every second. But when there is a situation where the patient is just going to have an advanced illness or they are going to be terminal, we do get recommendations and we'll take them onto either program. A lot of our patients on the palliative program tend to be younger because younger people get advanced illness. I have one of my favorite stories is we had a 40-year-old man who was waiting for a liver transplant, and he was very, very sick, and we were able to get in there and provide palliative support for him and his family. And then he received his liver and he was signed off the program because he was doing so well. He just didn't need to see us anymore. So those are the ones that really touch my heart and make me really, really excited about the program and where it's going. We also support patients when they are newly diagnosed with cancer, for example, and they're going through chemo, we'll go out and support the patient and family through that period of treatment. And then when they get better, as a lot of patients do, then they get signed off the program. Our average length of stay is about 4 months. We do have some patients, especially MS patients, who kind of stay on for a year because they tend to go up and down with their illness exacerbation. But most of our patients sign on and get better. About 30% of them, which you would find with any advanced illness population, do convert to hospice. They don't get better, but 70% of our patients get better and are signed off because they're stable. Are there any questions from the remote areas? No?
So you said that there are several 60 or so hospice care centers in southern Nevada. How do we evaluate, and when do we evaluate them? How do we evaluate them, and when should we now start looking for our hospice?
So it's always a good idea to educate yourself about your healthcare options, and it's probably a better time. I've been doing this for a really long time, and what I've seen is it is much more compassionate for the people you love and really for yourself to start having those conversations when you're far removed from actually needing to have it. So the most peaceful and most loving, I think, transitions occur when the patient and their spouse or their significant other, they've sat together and said, okay, what do we want it to look like when we're too sick to take care of ourselves? What do I want if I can't speak up? And they fill out an advance directive. They discuss it with their children once they've made the decision. And then when you're sitting in that ICU with the patient and the children, it's the hardest moment in your life. I'm sure at this point you've all lost someone close to you. You're numb and you can't think and you don't know what the right thing to do is. And if that person that you love has already spelled it out, it's so much easier to make those decisions not to intubate or to intubate. I'll give you a funny story. My father-in-law, he is a non-compliant diabetic. He's just an old bachelor and he's going to do what he wants to do. He calls me for everything clinical. But my sister-in-law, who's a stay-at-home mom, God bless her, she is his medical power of attorney. And my husband asked him one day, he said, Pops, why is Katrina your medical power of attorney? And he said, well, because Carolyn will take me off the vent, and I don't want that. So, and it makes perfect sense. He wants someone who's going to make the decisions he wants, and it's his right to make that decision, that if he wants every last second of this planet he can get, that's his right to make that. But the fact that he's made that statement makes it so much easier for us while we watch him eat whole cakes when nobody's looking. So, but as opposed to my Grammy, she ended up with leukemia, and she said to us starting a year before, do not keep me on anything artificial. I'm 83, I've had a great life, don't do it. And I sat there and held her hand while she passed, and it took everything in me not to run into the hall and say, nurse, but I knew it's what she wanted. So it's just so much better if the patient and family start making those decisions well away from the actual moment of needing the decision. And as far as researching who to choose, there are a lot. So I would go on, one in a year you're going to be able to use that Medicare website, but you can interview them, see how many patients they have, ask them detailed questions. You know, how many visits a week can I expect? What are your patient satisfaction scores? Do you have an inpatient unit? Because there aren't very many hospices that have inpatient units. Inpatient units are independently owned, acute license, so same as a hospital, and they're equipped with 24/7 nurses, private rooms, and inpatient hospice. I don't know how many of you have visited one, but they're very serene places. They're places that are built for patients and families to go through a change of life in a respectable and dignified way. A lot of the hospices contract with nursing homes to provide inpatient care, and they will say, oh yeah, we have an inpatient unit, and what they actually mean is a nursing home. So it's very important that you ask them, which facility do you provide inpatient care at, even if you don't need it that day. Where do you provide inpatient care? And then go take a tour so that you can see it with your own eyes.
went through that, my husband and I went through that in 2012. And he had radiation at Comprehensive Cancer Care. And then we knew that was not going to cure him, but it bought us 5 months. Excuse me. We made our funeral plans. We signed our DNRs. We did everything like that. We knew what he wanted, what I wanted, and our children knew and agreed with it. And I was in the hospital when he was very ill. And for respite care, they took him somewhere over around Summerlin for 5 days of respite care. And I don't know what we would have done without hospice, our whole family.
Yeah, it's something Medicare does right. Thank you for sharing that. And
They
did
did
it make it
everything.
easy?
They came in, they had the bed, they had the commode, they had everything we needed when we were in the house. And then when we moved to a retirement community, they again, the CNA came in and bathed them 3 times a week. She went out to the respite care and bathed them, and he had the continuous care of the same person. It was wonderful.
Yeah, it's
Very
wonderful.
supportive.
Thank you for sharing that. Any more questions? You have a lot more questions about hospice than palliative care. Any others? Do you feel like you have a good understanding of the difference between hospice care and palliative care? The palliative care is for people who are getting better. They're doing everything they can to get better. But it isn't skilled care. It's just more of someone to come in and help you navigate the complicated medical system. And then hospice care is a type of medical care reserved for people who have a terminal diagnosis.
No more questions for Carolyn? Anybody want to share an experience, positive or otherwise, with Carolyn, and she can share it with the remote sites? All right, well, I want to thank you so much, Carolyn, for joining us.
Thank you for having me.